Raw local honey. Not the plastic bear on your supermarket shelf. That product has been heated to 70 degrees Celsius or above, filtered, and stripped of the enzymatic machinery that gives honey its antimicrobial function. What we're cataloging here is the unprocessed form. Water activity below 0.6, pH between 3.2 and 4.5, and a live biochemical payload that makes bacterial survival a thermodynamic problem before it becomes a chemical one. Two primary actors. First, glucose oxidase, an enzyme secreted by bees into the hive product during production. In pure honey, the enzyme is dormant, too concentrated, not enough free water to run the reaction. The moment honey contacts wound exudate, dilution activates it. The reaction converts glucose and dissolved oxygen into gluconic acid and hydrogen peroxide at approximately 1 millimole per liter, low enough to be non-cytotoxic to healing tissue, high enough to disrupt bacterial membrane integrity. For scale, that is nearly 1,000 times less concentrated than the hydrogen peroxide in your medicine cabinet. Second actor, B-defensin-1, an antimicrobial peptide deposited during processing at the hive level, effective against gram-positive organisms and a subset of gram-negative species. Processed honey loses most of this. Heat above 60 degrees Celsius denatures both glucose oxidase and defensin-1. The remaining product is essentially flavored sugar syrup, osmotically useful but enzymatically dead. Osmolarity alone at 2,000 or more millismoles per kilogram still creates a hostile environment for bacteria through physical dehydration of cells, but you lose the chemical cascade entirely. Save this video. The next entry introduces a third mechanism that raw honey does not carry at all. Manuka honey, sourced from Leptospermum scoparium, the Manuka scrub native to New Zealand and parts of southeastern Australia. The distinction begins in the plant's nectar, which contains an unusual compound called dihydroxyacetone. During maturation in the hive, dihydroxyacetone undergoes a non-enzymatic conversion, chemically similar in mechanism to early-stage Maillard reactions, producing methylglyoxal. That compound is what separates this product from every other honey in the therapeutic category. Methylglyoxal concentrations in commercial Manuka honey range from 83 milligrams per kilogram at the entry tier to over 800 at the high end. Below 150, the antimicrobial effect is minimal and doesn't justify the price premium. Above 250, the effect becomes clinically relevant. Above 400, you are targeting organisms that most standard topical antiseptics handle poorly, including methicillin-resistant Staphylococcus aureus. If you're already running through these entries for your prep stack, drop hardened and ready in the comments. That tells me the correct people found this. The mechanism behind methylglyoxal is non-peroxide based, which matters operationally. That distinction is coming in a later entry. First, the sterile version. Medical-grade honey. I pulled the sterilization literature on this specifically because the intuitive move, boiling your honey before applying it to a wound, turns out to be the wrong call, and I needed to understand exactly why. The hospital standard formulation takes high-grade Manuka and runs it through gamma irradiation at 25 kilograms. This eliminates Clostridium botulinum spores and achieves clinical sterility classification. The critical finding: gamma irradiation at this dose does not destroy glucose oxidase activity or B-defensin-1. The enzymatic payload survives intact. Boiling achieves spore reduction at the cost of the therapeutic mechanism. Proteins denature above 60 degrees, and you are left with a sterile product that has lost the function you needed. Products like product placeholder, MediHoney carry Food and Drug Administration, Class II medical device clearance in the United States, and CE marking in Europe, with standardized, batch-certified methylglyoxal concentrations per unit. Raw honey gives you the kinetics without the sterility guarantee. In an austere field environment, that trade-off is operationally manageable. In a clinical setting, it isn't. Subscribe and stay current. The field kit sourcing breakdown follows in the archive. Honey-impregnated dressings. 3 formats are operationally relevant: Alginate, Hydrogel, and foam. Each governs delivery kinetics differently. Stay rational on selection. Calcium alginate dressings carry 40 to 70% honey by weight embedded in a calcium alginate fiber matrix. As wound exudate contacts the dressing, the osmotic gradient pulls moisture outward from the wound bed while honey is released inward toward tissue. Release is sustained rather than immediate. The antimicrobial environment persists across the full dressing interval without continuous reapplication. Hydrogel formats introduce a moisture component for dry or eschar-covered wounds, where pure osmotic action would desiccate viable tissue rather than aid debridement. Foam dressings absorb higher volume exudate while maintaining a honey contact layer, indicated for moderate to heavily exuding wounds. Plain topical honey applied directly works, but it runs off, pools at wound margins, and creates inconsistent contact time. Dressing architecture solves the contact time problem and the moisture control problem simultaneously. Products in this category include product placeholder, Algivan, MediHoney Alginate Rope. The format you select determines your dressing change interval. That protocol is the next entry. The application protocol is a sequence, not a suggestion. Wound bed preparation first. Irrigate with normal saline using a 20 milliliter syringe and blunt tip cannula. Approximately 20 milliliters per 5 square centimeters of wound surface. This removes loose necrotic material without damaging granulation tissue. Honey quantity, 20 to 30 grams per 10 square centimeters of wound area, enough to maintain contact across the full wound bed without runoff. For cavities and tunneled wounds, fill loosely using a blunt applicator. Tight packing compresses tissue and disrupts the osmotic gradient. Cover with a secondary absorbent dressing to manage exudate volume. Dressing change cadence. Every 48 to 72 hours for actively infected wounds. Every 3 to 5 days, once the wound bed is clean and granulating. Here is the counterintuitive operational rule that most improvised field guides get wrong. Do not heat sterilize your honey supply. Boiling achieves spore reduction at the cost of glucose oxidase and defensin 1, the two enzymatic actors that make honey functional as an antimicrobial agent. The thermodynamics are unambiguous. Protein denaturation begins above 60 degrees Celsius. Gamma-irradiated medical-grade product solves both problems. Raw honey in a genuine field scenario remains a usable option, but never boiled, never heated. That distinction between heat and irradiation is the single most commonly misunderstood detail in every improvised protocol this channel has reviewed. The full field kit reference, sourcing, product tiers, and wound classification matrix is in the archive. Subscribe now. The grid doesn't announce failure in advance. When I first ran the mechanism cross-check on Methylglyoxal against standard antibiotic resistance pathways, the detail that stood out was how structurally different the attack vector is. The molecule is an electrophile. It carries a partial positive charge that allows it to react with nucleophilic sites on bacterial proteins, the amine groups of lysine residues and the thiol groups of cysteine. These reactions modify the targeted proteins irreversibly. The structures affected include ribosomal components and key glycolytic enzymes, catalysts bacteria require for energy production. When those pathways get glycated, the organism's metabolic throughput collapses without the bacterium having any enzymatic response available. The effective threshold for bacteriostatic activity sits at approximately 150 milligrams per kilogram in vitro assays. Bactericidal concentrations against common wound pathogens, Staphylococcus aureus, Streptococcus pyogenes, begin around 250. Against methicillin-resistant isolates and Pseudomonas aeruginosa, which demonstrates partial resistance due to outer membrane characteristics, effective concentrations push above 400 milligrams per kilogram. The mechanistic distinction from peroxide killing matters here. Bacteria produce catalase as a primary defense against hydrogen peroxide, neutralizing it before it reaches cellular targets. Methylglyoxal bypasses that defense entirely. There is no cataloged bacterial enzyme system that neutralizes electrophilic glycation at concentrations present in high-grade Manuka product. Stay invisible. Stock the higher-grade tier quietly. The osmotic and enzymatic mechanisms run in parallel. Next entry covers how the osmotic layer creates its own independent failure condition for pathogens. Glucose oxidase is a protein incorporated into honey during production at the hive, secreted from the hypopharyngeal glands flanking the bee's pharynx. In pure undiluted honey with water activity below 0.6, the enzyme is chemically inert, not denatured, not destroyed, but dormant for lack of the free water the reaction requires. Contact with wound, exudate, provides the dilution trigger. The reaction proceeds. Glucose plus dissolved oxygen yields gluconic acid and hydrogen peroxide at approximately 1 millimole per liter at wound dilution ratios. The gluconic acid byproduct drives pH further below baseline, compounding the already acidic environment. Simultaneously, osmolarity at 2,000 or more milliosmoles per kilogram sustains a water activity gradient at the wound surface that physically dehydrates bacterial cells, a process called plasmolysis. This is a thermodynamic constraint, not a biochemical one. Bacteria cannot evolve resistance to osmotic dehydration the way they evolve resistance to an antibiotic because the force is physical, not molecular. The result is layered. Chemical hydrogen peroxide activity, gluconic acid acidification, osmotic plasmolysis, and, in Manuka product, Methylglyoxal glycation. 4 independent failure modes operating simultaneously against a bacterial population at the wound surface. If you're cross-referencing sourcing options while running through this, the link is in the description and the archive is still open. The next entry decodes the label so you know what you're actually purchasing. 2 grading systems appear on Manuka honey packaging, and they measure different things. You need to understand both before making a purchase for a wound care application. The unique Manuka factor rating is an umbrella metric developed and administered by the unique Manuka Factor Honey Association in New Zealand. Numerically, UMF-10 corresponds to approximately 263 milligrams per kilogram of methylglyoxal. UMF-15 maps to approximately 514 milligrams per kilogram. UMF-20 sits at approximately 829. Below UMF-10, no validated therapeutic claim applies to the product. UMF-15 or above is the indicated range for active wound infections. UMF-20 and above is relevant for biofilm-forming organisms and high-burden cases. The MGO label skips the proprietary system and states methylglyoxal concentration directly in milligrams per kilogram. MGO 250 plus maps to UMF-10, MGO 500 plus to UMF-15. Counterfeiting in this category is substantial. Some products labeled as Manuka originate partly or entirely from non-Leptospermum Scaparium flora sources. Verification protocol: confirm the unique Manuka factor. Honey Association certification mark or independent laboratory certification from Analytica Laboratories. Leptosperin, a chemical compound unique to nectar from L. scaparium, is the most reliable molecular marker of genuine origin. Certified product now includes leptosperin data on the certificate of analysis. Prepare in silence. Check the certificate before you buy anything. Final entry covers the limits of the system. I'll close with the operational limits, because knowing where a tool fails is as critical as knowing where it works. The wound types that respond to honey-based treatment: infected and colonized wounds, chronic wounds in diabetic and venous insufficiency cases, burns presenting with surface contamination, and surgical wounds with dehiscence or secondary infection. High bacterial burden environments, where standard wound care protocols stall. The primary safety constraint involves Clostridium botulinum spore content. For ingestion by infants under 12 months of age, spores represent a genuine risk. Immature intestinal flora cannot compete with germinating organisms. For topical application in adults, this risk does not apply. Spores do not germinate through intact or healing skin, and systemic absorption from topical honey application is not a documented concern. Gamma-irradiated medical-grade product eliminates even this theoretical consideration. Dressing removal: soak the dressing with saline for 3 to 5 minutes before peeling. Dry removal risks mechanical debridement of fragile granulation tissue at the wound margin. Regarding antibiotic interactions, honey and systemic antibiotics do not interfere, and some published data indicates synergy against methicillin-resistant Staphylococcus aureus when used in parallel. Storage for sealed medical-grade units. Room temperature, away from direct light, 2 to 3 year shelf life from manufacture date. Raw honey properly sealed demonstrates indefinite stability. Archaeologists recovered antimicrobially active product from sealed Egyptian tomb vessels dated over 3,000 years old. That is the correct analog backup for a field kit. Stack it accordingly and check the description for the sourcing index.